All right. Well, thanks everybody for jumping on the call today. We're very excited to give everybody a good briefing on the goings on in Nevada. Admittedly, I'm going to let Derek at the Value of Care Coalition provide a lot of the insights around the Nevada process because I think he's got a little bit more insight and intel on what's going on with the legislation that is happening in Nevada. Um, but we just at the Partnership to Improve Patient Care are excited to provide some background to advocates in the state on the issues related. As many of you may know who have participated in these kinds of webinars and calls with PIPC, our focus has really always been on the implications for discrimination, as a lot of our membership represents the patient and disability communities. Um, so with that, my name is Sarah. I am the executive director of the Partnership to Improve Patient Care. Um, I come at this with, a lot of passion. Our chair, Tony Coelho, who was actually the original author of the Americans with Disabilities Act and has, really comes to this personally as well as a patient with epilepsy. So I'm going to go ahead now and just share the slides and get going with a slide presentation, if that's okay. And then I think we're probably pretty close to having a quorum here. So let me put it in slideshow view. There we go. Look at me being technical. Okay. So today, we're going to talk about the quality adjusted life year and similar measures and what the implications of their use and reference have for people with disabilities and older adults. As I mentioned earlier, our chairman, Tony Coelho, comes at this from a very personal perspective as the original author of the Americans with Disabilities Act and a patient with epilepsy. So Tony, when we created PIPC way back in 2008, 2009, Tony was asked to lead this organization in an effort to create what is now called the Patient-Centered Outcomes Research Institute. And within the statute of PCORI is also a ban on the use of quality adjusted life years in recognition of the potential for discrimination that would emanate if we were relying on those types of studies to make healthcare decisions. And so when we talk about this measure called the quality adjusted life year, it's important, it's really about the math, right? It's a very mathematical type of equation. What happens in the quality is when in the conduct of what's called a cost effectiveness analysis or a value assessment, you'll hear it referenced in different ways, or a health technology assessment is another term that you may often hear. The quality adjusted life year is sort of the calculation of cost effectiveness that's often used. Um, and that can be used as a benchmark for, payers in terms of how they cover things, um, or in terms of how things get priced and reimbursed. So the way the measure works is that a one is optimal health, a zero is death, and people with a chronic condition or a disability tend to fall somewhere in between. Um, so this is actually a much better slide for explaining that. So I like to use the multiple sclerosis example in the middle. Essentially, a person living with multiple sclerosis would go into that calculation as a zero point 0.5 or half the value of somebody who's living at optimal health. So if you think about this in the context of a quality adjusted life year is going to look at what impact a treatment has on improving someone's quality of life. If you're going from a zero point 0.5 to a zero point 0.7, a zero point 0.2, as opposed to going from a zero point 0.5 to a 1, um, then the impact and the value of said treatment will look smaller because the incremental improvement in health care, quality of life will look to be lower because you're not getting to optimal health, right? When a treatment, so for people with optimal health treatments, when you get to optimal health, treatments tend to look more quote unquote cost effective. And for many people who live with chronic diseases and disabilities, right, who will never get to a one, it becomes sort of a bias in the math and the system in terms of how we value treatments. And sometimes you'll see, particularly what we have noticed is that in state-based legislation where they're looking at these kinds of value measures, sometimes the state, sometimes the language that's used to quote unquote bar the use of quality adjusted life years will limit their the ban on their use to life extension. The challenge with that is that it's not always just in the life extension calculation where the discrimination happens. It's also in the calculation of quality of life improvement. Um, so, it is important, I think, to understand that the quality is not just a discriminatory measure in terms of how it looks at life extension, but also in how it looks at improvements in quality of life. And that's when you get to this measure called the equal value life year gains, which is referenced here in the slide as the EVLYG. That equal value of life year gains uses a lot of the same health utility measures that the QALY uses in terms of how they translate the quality of life improvement, which is typically based on large population surveys where there is inherent bias. And so the translation of all of that information into the utility scores also is biased and discriminatory, making both types of measures really not suitable for use in the context of making decisions on behalf of a patient or a disabled population. And the other challenge is that in terms of how we view the value of life or the quality of life, people who with these conditions will have their own, just somebody who lives with one of these conditions may not view themselves as having a quality of life that is low, whereas in these calculations, that's where the point 0.5 comes from, right? A perception that somebody who's living with this condition has a quality of life or a value, it values their lives lower. Um, and that comes from the concepts that come from these larger population-based surveys where someone may say, hey, I wouldn't want to live with that condition, so I'm gonna give it a lower quality. I'm gonna check off the box that says that that's not a quality of life that I would value. Those kinds of surveys feed into these calculations, and that's part of the problem. Also, value assessments, just in general, in terms of how they're put together, tend to rely on clinical trial data that isn't necessarily reflective of real world experiences of people who live with these different types of conditions. And we all know that clinical knowledge takes a long time to make its way into the research literature. So, to the extent that these value assessments are used to drive clinical decision making, there's a lot of risk in that when clinicians really know better because they're more at the helm of the experience with their actual patients. So the National Council on Disability actually did a really big study on the quality adjusted life year back in 2019, which is often cited and used in these discussions. Um, the National Council on Disability found that the quality was discriminatory. They ended up providing recommendations related to the use of QALYs that basically said Congress should avoid any provisions um, that would look at cost effectiveness as the basis for restrictions. They also said that we should be avoiding reference to other countries that use these quality adjusted life years um, to model as the model for their own pricing, because by referencing their pricing, we're then essentially incorporating their use of the quality adjusted life year into our country. And I like this slide because there's a really long history related to this. The quality adjusted life year and the advocacy against it has a very long history. So it goes back 30 years. In 1992, actually, Oregon tried to use a quality adjusted life year to determine its prioritized list of services. That happened right after the ADA, the Americans with Disabilities Act, had passed in 1990. And at that time in the Bush administration, they said, no, you can't use QALYs because to use QALYs, to create this prioritized list of services in Oregon under a Medicaid waiver, was determined to essentially discriminate and to devalue certain services for people with disabilities. So forcing Oregon to kind of go back to the drawing board. And then later, there was a quality ban passed as part of the Affordable Care Act, which is what I was talking about earlier in the context of the Patient-Centered Outcomes Research Institute. The way that that quality ban was drafted was that it barred the use of QALYs in Medicare coverage and reimbursement decisions. And then moving forward, again, it was referenced in the IRA in the context of Medicare negotiation, barring the use of discriminatory value assessments. Again, in the new Section 504 rules that came out last year, barring the use of discriminatory value assessments. So there's a long history here of advocacy and policy at the federal level against the use of quality adjusted life years. And so there are a lot of experts in the field, and particularly out of the disability community, that recommend against the use of or the reference to these types of quality-based decisions. So the reason that we're highlighting the quality so much in the context of this discussion is that there is pending legislation in Nevada that would essentially reference Medicare's maximum fair price for setting an upper payment limit for drugs whose price has been negotiated at the federal level. And while I mentioned earlier that the Inflation Reduction Act had included some provisions that limited the use of discriminatory value assessments in the context of Medicare negotiation, we've been very, very concerned that despite the bar, despite what's in the legislation, the explanations that came out last year in December actually showed that Medicare did reference quality-based studies, um, giving us pause and I think leading us to question the process by which they made those decisions. We're also really concerned about what's going to happen in the future in terms of how those maximum fair prices are established because of recent proposals in the Trump administration to look to other countries, which is in direct contrast to the National Council on Disabilities recommendations. And I should point out that the National Council on Disability is a federal government created independent but government agency that advises Congress and the White House on disability policy. So they come with a lot of credibility on these issues, and have been very clear that they actually recommend against doing exactly that. So this is just to show in those explanations that I talked about from last December, these were some of the studies that were referenced in those explanations related to how the Medicare negotiation process, what information they used as part of that process, and on which they based the prices that were chosen. So several of these studies are just quality-based studies that were cited in those explanations. And so some of the concerns that we have had and we have expressed over to CMS and related to how these maximum fair prices are created is, number one, I think we've had a lot of concerns around the engagement process and how patients are engaged and sharing their experiences about, how they view the value of these products, what impact they have had on their own lives. And patients also, I think, have been very concerned about what will be the process after these prices are negotiated. What will be the process for their engagement if they start to see access challenges, whether it's in response to formulary placement decisions or other types of utilization management that might be imposed upon them by the payers. Um, so that process for sort of like the post engagement haven't really been established. And we do know, just at least so far that from a pre-engagement standpoint, there has been it seems that the patient engagement process hasn't had a big impact on the ultimate decisions that were made by CMS related to these maximum fair prices. And then, as I mentioned before, we're obviously very concerned about the reference to the use of QALYs and QALY-based studies. And when they did those explanations too, it was very unclear how they used those studies in their decisions. There's not a lot of transparency there. And as I mentioned before, too, we're also very concerned about what's coming. We do think that this concept of most favored nation may be incorporated into how these maximum fair prices are established, which is to reference another country's pricing decisions that were based on these quality adjusted life years and similar measures. We're seeing the threat not just in Medicare, but in Medicaid. But there is a possibility that they could just take those prices and incorporate them into the Medicare negotiation and use those as the kind of the benchmark. So this concept of referencing other countries is, as I mentioned, has been strongly opposed by the National Council on Disability. Um, it's also been strongly opposed by others. Um, the CMS proposed rule that actually advanced something called Most Favored Nation back in 2020. In the CMS actual proposal to do that, there was an acknowledgement that most of the savings from doing that were going to come from beneficiaries not accessing their drugs, and that it was going to create problems for physicians who now were going to be who are basically going to have their own payments cut as a result of the policy. And when these physicians potentially choose not to offer those drugs, that would force patients to have some, potentially serious access challenges. Um, so I think, devil was in the details. And then also in response to that, there have been letters from advocates across the spectrum of patients and people with disabilities to ask policymakers to reject those types of policies, many of which have come directly from the disability community that is most impacted. We've sort of seen what happens with these policies in other countries. It tends to translate into patients, people with disabilities, and older adults, people at the end of their lives, being viewed as less valuable in the system, and therefore to have their care denied or delayed. When we're really concerned too about, when these policies get passed, what implications they then have for formulary placement and utilization management, which I know a lot of folks have experienced in their own care and with their own plans. And so we're watching a lot of these issues, particularly as I mentioned in the earlier part of the discussion, that Section 504 of the Rehab Act that had a protection against the use of discriminatory value assessments, but it's also being challenged by several states' attorney generals. We're still sort of waiting to see what happens with that. Um, and we're also watching this group called the Institute for Clinical and Economic Review, which does a lot of these quality-based studies. They're also pushing this equal value life year gained measure as an alternative that still has a bias in terms of how they calculate the quality of life improvement piece of that calculation. And then we're also watching state prescription drug affordability board debates, which also are using international sources. And fundamentally, different people respond differently to the same drugs. So we hope that, what the goal here really is to protect access to care. So I'm going to turn it over now to Derek.
All right. Well, thank you, Sarah. I will attempt to share my slides as handily as you did. One second here.
Yay.
Okay, I think we're in the right spot. We'll make this full screen. And off we go. Yes, there we go. Okay, let me know as we go, folks, if you have questions. This is set up so as a meeting so that it can be interactive. If folks do have questions as we go, feel free to interrupt me, raise your hand, do whatever polite thing we do on Zoom. But I'm happy to handle these as we go, or of course, at the end, there'll be time for that too. Sarah did a really, really good job of laying the groundwork for the idea of why reference pricing, and two of the most common references that we see, whether it be MFP or a basket of other countries' pricings, present challenges, particularly for certain segments of the population who may need these drugs. I'm going to talk a little bit about how the states are looking at using this as a way to set upper payment limits and what we know about the impact of upper payment limits to cost and access for patients. So many of you know me and have seen this or a version of this before, but for those who don't, my name is Derek Flowers. I head the Value of Care Coalition, and our defining mantra is that value should be defined by those who know, patients and providers, not necessarily bureaucrats or academics or economists, but rather the people that rely on treatment, that see the benefit of treatment, and who prescribe treatment to care for their patients. We know medicine can be expensive, but so are policies that stifle innovation and restrict access. And what we believe is that patients and providers value the things you see on this screen. I don't think I'll get a lot of disagreement amongst people in this group about that. So this is what we like to see as the basis for public policy. But unfortunately, some policy approaches overlook those things. And one example in our mind is reference pricing. So to define this a little bit, let's see if I can navigate this. Reference pricing is a policy that includes a mechanism to bypass the process of the Prescription Drug Affordability Board and set an upper payment limit. Our organization spends a lot of time talking about Prescription Drug Affordability Boards, or PDABs. A lot of you on this call have been engaged in PDAB legislation or with existing boards. As you know, when these boards are set up, their goal is to assess the price of specific drugs, and then if they're deemed unaffordable, set an upper payment limit or a price that nobody in the state can pay more than that drug, or be reimbursed more than that price, rather, when that drug changes hands. The idea of implementing reference pricing at the state level is simply an idea to make that process go away. It gets rid of the whole Prescription Drug Affordability Board and instead sort of imports a price set by someone else as the upper payment limit. So there's no opportunity for public comment. There's none of the back and forth in policymaking that we see with PDABs, just sort of the end result that happens automatically. As I mentioned, it uses an external benchmark to determine the price of a drug. We're talking here about the MFP that Sarah talked about, and in sort of circular fashion. As she mentioned, it's possible that most favored nation pricing could get factored into MFP prices going forward. So it's almost a double benchmark if that happens. These policies could apply to state, to commercial, state, Medicaid health plans within Nevada. And as Sarah mentioned, they can lean on discriminatory and one-size-fits-all metrics like the QALY. In setting these prices as they're arrived at, they might rely more on health economics data, third-party negotiations that have nothing to do with the population of Nevada, or foreign governments than on input from patients and providers within the state that's being impacted. They're going to target innovative medicines that help patients living with debilitating conditions, and they don't consider the experiences of local clinicians or the needs of individual local patients. How could they when the price is set so far away from home? So as we think about reference pricing, there are some questions that come to mind. And we might think, I'm trying to navigate this again. We might ask ourselves, does the reference price ensure that no discriminatory metrics will be used? Well, as Sarah mentioned, the fact is they don't. Do they take a holistic look at all the cost drivers in the drug pipeline? Are they looking at, PBMs, wholesalers, pharmacies, everybody in between? Are they looking at the R&D process, all the ingredient costs, any of that stuff? No, they're not. They're simply importing a price that somebody else set. Do they include a mechanism to make sure any potential savings are passed to patients who need the drugs? That's not something that we've seen happen with PDABs, and there's no reason to believe that that would happen with the MFP bill in Nevada. In fact, in the bill, there's nothing that says the person at the pharmacy counter is going to see a reduced cost when they go to pick up their drug. Does it guarantee that the price won't lead to decreased access? It does not. There's nothing in AB 259 that guarantees continued access for patients. And as we'll see in a couple slides, in fact, it's likely that access is diminished when price caps are put in place. Does it allow for input from impacted patients and clinicians? Again, it doesn't. Like we talked about, the price is set so far away from home that it's impossible for local people to have an impact in those discussions. In fact, the price is just automatically set in Nevada when someone else sets it, making it even more difficult to be part of that process. And like Sarah mentioned, to the extent that there is a process for public input to the MFP price negotiations, it's not clear how much that input is valued or weighted. And finally, does it take into account local populations and local needs? In this instance, it does not. The bill that we're talking about in Nevada would say that the price of a drug is negotiated by CMS for use in the Medicare program is the upper payment limit for a drug in the state. And as you know, the Medicare program serves a specific population nationwide, and that population may look different than the population in any given state or locality. And so in this instance, we're taking a price that's meant to serve the Medicare population and forcing it on everybody in Nevada. So if the answer to no to those questions is no, then we ask ourselves, how could patients and providers support the policy? Here's what we're talking about. Again, Nevada AB 259, referencing the maximum fair price. That's the upper payment limit for the drug at the maximum fair price. And Sarah did a great job of defining that already. But it's not just us talking about this. It's not just patients worried about it. It's not just some providers worried about it. The fact is that payers are speaking out on upper payment limits as well. And remember, when we've talked about prescription drug affordability boards in the past, we've spent a lot of time talking about their goal, which is to set upper payment limits. But using the MFP as a reference price is just another way of setting upper payment limits. And so I think we would find payers saying the same thing about this as well. They're saying this, they're saying lower prices may not be preferred overall, since upper payment limits fail to consider the entirety of the supply chain, such as PBMs, distributors. Payers aren't going to make up the difference. They say payers are not going to pass their savings, if there are any, on to individuals. It's not realistic, and somebody's going to need to make up the difference. They say that the cost of implementing these programs is going to have to be absorbed by somebody, and the carrier is not going to be the one to absorb it because we might reduce our profitability. That's very honest feedback from the health plan community. They're also talking about utilization management. They're saying it'll undoubtedly go up with upper payment limits, whether for the drugs subjected to them or for the competition. They're saying that UPLs will alter how formularies are determined by plans, which means changes to patient copays and coinsurances. And they're saying that patients may not be able to get their preferred drugs anymore, and that alternative drugs may have higher out-of-pocket costs and require a prior authorization. And in fact, there's a study out just, I think, last week from Pioneer Institute that looks at some of the drugs that were subjected to the first round of Medicare price negotiations, and what people in the Medicare program are seeing is their out-of-pocket costs going up on those drugs this year in prep for the MFP being applied on January 1st. So what we're seeing on this slide is the very people, the health plans, the actual people who determine the cost a patient pays for their healthcare and the drugs that they have access to based on their formulary. These are the people that make those decisions. They're saying that patient costs will go up and that patient access will be diminished. These are the people we should listen to. But let's also look at what's happening to pharmacies. There was a recent national survey of independent pharmacists that found a jaw-dropping 93.2% of respondents, so of these pharmacies, have already decided not to stock drugs in the Medicare MFP program, or they're considering not stocking them. They say that about 61% are considering not stocking one or more of the first 10 drugs selected, and about a third have already decided not to stock one or more of the drugs listed in the first round of MFP negotiations. And the reason they're doing that, they're saying that they're concerned about reimbursements. They have to pay so much for a medicine, and then they have to wait some amount of time. They don't know what it is, and then get reimbursed, and they're concerned that it might be for less, and they just can't float that. And so you're seeing access being diminished here too. So if the people who decide what patients can receive are saying access might be diminished, and if the places you go to get your medicine are saying they might not have it anymore, there's good reason to believe that access challenges could occur with implementation of these policies. And so we would say to ourselves, it's one thing that Medicare is doing it, but why would a state double down when these uncertainties exist? So what's it mean for patients? Here we go again. Health plans, people who determine these things are telling us they won't see savings and access will be diminished. Pharmacies are telling us they can't stock the drugs. And so what it means for everybody in Nevada, if this bill is passed, is that access could be diminished while savings might not be achieved. So here's the bill, AB 259. Where does it stand today? This bill has passed the Assembly. It's expected to pass the Senate yet this week. There are only a few days left of the legislative session here, so lawmakers are in a rush to get this done. And an advocacy opportunity exists for folks on this call, your friends, peer organizations, and members. The opportunity here is to contact the governor next Monday and urge him for a veto. Session ends on Monday, so we assume that the bill will have passed by then and made its way to his desk. He has a very short window of time to act. He has about 10 days to either sign it or to veto it. In the past, he's vetoed a similar bill, and so we believe that if patients and providers and caregivers raise their voices and express concern about the MFP and about upper payment limits and their inability to have input into this process and take part in decisions that are made, there's an opportunity that he may veto the bill again. You can see on your screen contact info for the governor and for key members of his staff. Please take that down. We'll be happy to provide it afterwards as well. But the time to act is now. Start drafting letters today, reaching out to your members and urging them to do the same, because the bill, like I mentioned, is likely to pass this week and be on the governor's desk as early as Monday. So you say, what can organizations do? Well, if you're a representative of an organization in this meeting, alert your local members to AB 259, explain to them all of the challenges with the MFP that Sarah laid out, explain to them what happens when upper payment limits are implemented as I laid them out, because we're hearing health plans say it, we're hearing pharmacies saying it, access could be challenged. Send a letter to the governor next Monday asking him to veto AB 259. Again, that contact info is on your screen. Also, if you're interested in a sign-on letter, that's a letter that another organization leads, but several organizations sign on to an agreement. Reach out to Jennifer Zins at the address listed there at the bottom of the screen. She works with a lot of organizations in that and is helping to coordinate that effort. By the way, I should mention it's great to do both. If your organization wants to send a letter on its own, please do so. And then also feel free to sign on alongside others in expressing concern about AB 259. And if you're an individual on this call, tell lawmakers why access to medication is so important to you. Let them know you have concerns that AB 259 might hinder access while not saving you any money, because there's no evidence so far that that's what's happening with the MFP and the Medicare program. Contact your legislator yet this week. Again, the Senate is where the action is right now. And then write Governor Lombardo as early as Monday, asking him to veto AB 259. And once again, the contact info for the governor and his key staff is there on your screen. And so finally, here's my contact info. If you have questions about anything I said with regard to upper payment limits, challenges with reference pricing, or the specific bill in Nevada, please feel free to reach out anytime. I'm at dflowers@valueofcarecoalition.org. And I'll pop up the screen for questions, but more importantly, I'll end the share screen and return us back to the meeting. So with that, any questions? I know that was a pretty quick run through. And I see now in the messages that I shared with you my note screens as we were talking, but I think hopefully you were able to see the full content. Let me just do one thing for everybody and pop back up the contact info for the governor's office so that maybe I can make it full screen and a little bit easier to read for folks. Here we go. Hopefully that's right and everybody can see that contact info there.
And Derek, this is on your Value of Care website too?
It is not. A lot of the PDAB information is there, but this Nevada specific information with regard to contact info isn't there, we can certainly add it. If you visit our advocacy page, you'll see the bill, be able to read the bill and see where it's been. But this is the contact info you would want to use.
Well, I'll just chime in. The Value of Care Coalition website, their advocacy site is very good for easily tracking what's going on in the states. We use it a lot.
Glad to hear it. Let's see, someone wrote in, are you seeing a pattern of similar legislation in other states? Yeah, we are. You know, the Prescription Drug Affordability Board legislation really came on the map last spring and continued this spring in a handful of states. But we're now seeing a few states lean more towards this reference pricing, and even states that are looking at the PDABs to go through the full process are giving a nod in their bills or in their rules towards using the MFP as a benchmark. My thinking is that if you're a state who's looking to cap prices on prescription drugs, going the reference pricing route may start to look more appealing, considering some of the struggles that we've seen from the PDABs that are in operation. And so, you know, Nevada's got this bill this year that I think is the most likely to make its way through the legislature. But there's a very similar bill with regard to MFP reference pricing in Rhode Island. And there's a couple bills in Connecticut that look at reference pricing through a little bit different lens, but would reference drug pricing nonetheless. And you know, going forward, I think we'll see more of that, and you may see other types of references being used as well.
So I would just point out too, just to add on to that, there's a group called the National Association for State Health Policy that puts these that has a bunch of different template legislation that they then go and pitch to states. And I think what we're seeing, and I think the reason we're seeing both prescription drug affordability boards and these types of reference pricing bills being advanced in multiple states at the same time is in large part because they're being pushed by this group called NASHB. A lot of that's coming from a concerted effort, and a lot of these entities are all getting their funding from the same place, from Arnold Ventures, which also funds the ICER, which does the quality-based studies, and then Portal, which is the entity that tends to inform PDABs, which is also getting funding from the same place. And then, you know, you kind of see a thread of this push for the use of these quality-based and these types of value assessments to use in the context of pricing, reimbursement, coverage. Anyway, it's something that we've been seeing for now over a decade, coming from the same place.
Right. Any other questions? All right. Well, key takeaways from me are simply that the Nevada bill is looking like it's going to pass, and so you know we should be vigilant and prepared to weigh in with the governor's office early next week. And again, feel free to reach out to me with questions or reach out to Jennifer if you'd like information about the sign-on. All right, very good. Thanks, everybody.
Thanks, Derek.